The virtual rainbow brings together LGBTQ+ youth and their families, community leaders, professionals, and healthcare providers to learn and celebrate diversity and inclusion. Thank you for joining, everyone, and welcome. Welcome, everybody, to our next presentation. I am very happy to introduce Dr. Katherine Mistretta. Dr. Mistretta is with the Bozeman Creek Family Health and will be talking to us today about medical management of gender transition. Dr. Mistretta, thanks so much for joining us. Go ahead and take it away.
Okay, perfect. So let me know if you guys have any questions along the way. I'm happy to stop. But let's go ahead and get started. So again, my name is Katherine Mistretta. I am a family nurse practitioner over at Bozeman Creek Family Health. And I like to say that I specialize in transgender healthcare. It's certainly a passion of mine, one of my favorite populations to work with. So today we're going to be talking about the medical management of gender transition. Oh, let's see, there we go. I have nothing to disclose nor any conflicts of interest. The objectives today, really, we're going to be talking about the medications that we use to treat gender dysphoria, gender incongruence amongst the youth, adolescent, and adult populations. So before we get started, I want to do a brief exercise. And my hope is that by doing this exercise, we'll all get a better idea of why it's important that people transition. So as we look at this very blank screen right now, I want you to envision yourself, envision who you are, how you present yourself, think about your gender identity, your gender expression, and think about how the world perceives that, how other people perceive you. So for me, this is me. I identify as a cisgender female. I identify as a mother, as a wife, as a clinician. I express my gender in a more feminine way. I tend to keep my hair long. I like to wear jewelry. And I think that the world around me perceives me this way as well. Take, for example, however, what happens if the world doesn't see me this way? And in fact, the world sees me this way. So this is a rather masculine, somewhat intimidating, perhaps male. And if the world sees me this way, and it's different than how I identify, there's discordance there, there's incongruence. And what that can lead to is what we define as gender dysphoria. So gender dysphoria is the persistent physical, emotional, psychological distress that's secondary to the discomfort that one feels when their assigned sex differs from their gender identity. And this is why we transition. This is why people transition, because when we transition, we're able to decrease that gender dysphoria. Things that increase gender dysphoria, physical characteristics, breast, genitalia, facial features, muscle mass, clothing, and especially being forced to wear clothes that don't align with our gender identity. Being misgendered, that can increase gender dysphoria significantly. Especially when it's happening in public or at schools. Having to undergo physical exams by clinicians, by others, that can be really dysphoric for people. And certainly adolescents who experience puberty, adolescents who have gender dysphoria can have increased dysphoria when they go through puberty. So we know why people transition, right? It's to alleviate some of that gender dysphoria. And so it's important to recognize the different types of transition. There's three kind of types of transition. They by no means need to be done in order, and by no means does somebody need to experience all three types of transition. But these are kind of the three options. Today we're going to be talking more about the reversible and the partially reversible. So reversible transition is basically that social transition where somebody might change their clothing, their hairstyle, their pronouns. They might be on puberty blockers like a GnRH agonist. And this form is completely reversible. So you can decide to not do it and go back to how you were previously living, and there would be no problem. Partially reversible transition is when we use medications like hormones or anti-androgens, and we use those medications to affirm one's gender. And some of the effects from that are reversible, and some of them are not. Some of them are permanent. And then we have the permanent transition, and that is any surgical procedure, vaginoplasty, phalloplasty, metoidioplasty. Any type of surgical procedure is very permanent, so you cannot reverse those effects. So before we start talking more about transition and the types of transition and the medications that we use for the different types of transition, it's important to understand how we diagnose gender dysphoria. So this is taken from the DSM-5, and this is the criteria that's needed in order for somebody to have a diagnosis of gender dysphoria. And throughout this lecture, we'll be talking about gender dysphoria and gender incongruence, and they're one and the same. So according to DSM-5, in order to be diagnosed with gender dysphoria, you have to have, or one has to have a marked incongruence between their experience and expressed gender and their natal gender. And this has to be present for at least 6 months. In addition, it has to manifest as at least 2 of the following. And I won't read through this list, but basically it's an incongruence between one's experienced or expressed gender and primary or secondary sex characteristics. It's desiring to be rid of your primary or secondary sex characteristics, a desire for the primary and secondary sex characteristics of the other gender, or a strong conviction that you have the typical feelings and reactions that align with the other gender. So you have to have at least 2 of those. In addition, the gender dysphoria must be associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. So once we have our diagnosis of gender dysphoria, we can then come up with an appropriate treatment plan. And I stress this, I really want to stress this, that all treatment plans are very much individualized. There is not an algorithm that fits every single person. And I think it's so important to use the guidelines and the information that we have and really individualize it and tailor it specifically for our patient that we're working with. There are 2 sets of guidelines that we have access to, or that are out. The Endocrine Society published some newer guidelines back in 2017, and they were updated guidelines from 2009. And the update was huge. They made a lot of really significant changes in these guidelines and made them much more appropriate and current to how we want to be practicing. So these guidelines are great. In addition, we have the Standards of Care, or the SOC-7. These were published back in 2011 by the World Professional Association for Transgender Health, or WPATH. And these are also great guidelines. So I use both of these when I'm coming up with a treatment plan for an individual. I take information from both of these guidelines. So let's start by talking about children and adolescents. So before we start talking about how and why we're going to, or how we're going to work with our children and adolescents who either identify as trans or have gender dysphoria, I really want to highlight the importance of assessing for gender dysphoria and the importance of supporting our trans and gender diverse youth. So this was information that was collected in a study from 2017, and it basically shows us, you can look at the health risk behaviors on the left, and then in the middle column, there's the trans and gender diverse youth column compared to our cisgender youth column. And what's so alarming here is that suicidal rate or suicidal ideation for our trans and gender diverse youth is upwards of 61%. Self-harm is 54%, depression 58%. And when you compare that to our cisgender youth, they're astoundingly different, right? So we clearly, trans and gender diverse youth experience these disparities at a much higher rate. But what's really interesting is that when we support, when our trans and gender diverse youth feel supported, when they feel supported by their parents, by their peers, by their educators, their clinicians, when they feel like they're in a safe environment, these rates of suicidal ideation, self-harm, depression, high-risk behavior, they decrease, and they more closely resemble those rates that we see in the cisgender peers. So this just really highlights the importance of, as clinicians, as really being aware and assessing our youth for gender diversity, for gender dysphoria, for any of that, so that we can make sure that we're offering them the proper support. And so when we have youth that come to us and they present with gender dysphoria or gender incongruence, the first step that we want to be thinking about is if it's appropriate to start them on a puberty blocker. This is the criteria put out by the Endocrine Society. And this is the criteria that we would use to see if an adolescent is eligible for a GnRH agonist, which we'll talk about, or puberty blocker. And really, the criteria is that they have to have a mental health provider who has confirmed their diagnosis. Their gender dysphoria has to have worsened with the onset of puberty. Excuse me. Any coexisting psychological, medical, or social problems that may interfere with treatment need to be addressed. And the adolescent has to have sufficient mental capacity to give informed consent. The adolescent also must be informed of the effects and the side effects of treatment, and you have to have a discussion about fertility preservation. They have to be given informed consent. Parents or caregivers need to be given informed consent as well. And then finally, you have to have a pediatric endocrinologist or another clinician who can identify where they are in puberty, who agrees that a blocker is appropriate, and who can confirm that there are no other medical contraindications to proceeding with a blocker. And so if you have met all this criteria, then you can go ahead and proceed with some type of puberty blocker. I do want to highlight kind of the informed consent, because our treatment is really, our treatment model is really focusing on this informed consent model. We used to rely heavily on letters from mental health providers and psychological evaluation, and now we're recognizing that the informed consent model seems a little more appropriate. And so I use informed consents that I get from WPATH and Fenway Health. And these informed consents are wonderful. They discuss the risks, the expected side effects, changes, both reversible and irreversible, of the medications that you're going to prescribe, whether that be blockers, whether that be feminizing or masculinizing hormones. And in these informed consents, they also talk about fertility preservation. It can be really a challenging question and a challenging concept to ask a 12-year-old to think about whether or not they want to have biological children in 15 years. But it's a really important conversation, and it's one that needs to happen prior to them starting blockers. Majority of patients who start blockers will then proceed to gender-affirming hormones. And so if you don't talk about fertility preservation, and if that's their desire, you may have made the decision for them, and that's not okay. So our options for fertility preservation are both oocyte and semen cryopreservation. So once you've reviewed the informed consent and everybody is on board, then you start talking about blocking puberty. Ideally, we do this around Tanner stage 2, and you can assess this by both a physical exam as well as you can look at LH levels, and those are generally going to be greater than 0.2 to 0.4. That indicates that puberty has started. If they have testes, then a testicular volume is going to be greater than 3 cc's, and again, that typically indicates puberty has started. So the idea with the starting a puberty blocker at Tanner stage 2 is that we want to see that puberty has started, but we don't want it to proceed or progress so that there's some permanent secondary sex characteristics. So we want to maintain a pre-pubertal status as much as we can. You can absolutely use blockers in Tanner stages 3 and 5. It just depends on how far they've progressed through puberty, and wherever they are, starting a blocker will sort of halt it and stop it, and it will prevent continued development of those secondary sex characteristics. And so the goals, what are the goals? Why are we doing this? Essentially, we use blockers to just press pause, to just kind of give everyone some time to explore their options, explore a possible treatment plan without that individual having to go through through puberty anymore, therefore causing increased dysphoria, right? Puberty is hugely dysphoric for so many individuals. And so we can kind of press pause on that, and delay those irreversible secondary sex characteristics. Again, it allows time for the adolescent, for the parents, for the social support, and even for the clinician to kind of get on board to come up with a proper treatment plan. In terms of our blockers, our first line option are the gonadotropin-releasing hormone agonists, the GnRHs. And these are commonly known as Lupron and Supprelin. Sometimes these can be very cost prohibitive. Insurance does not cover these very often, and so they're quite costly. And so it's not always an option for everyone, at which point then you can look at other medications like your progestins and your anti-androgens. So first, let's talk about our GnRH agonists. These medications create a continuous surge of GnRH, right? So GnRH is continuously secreted. It basically tells the pituitary gland to shut down and stop secreting LH and FSH. It's really important to note, though, that when you start this medication, initially you get a surge in your LH and FSH. So initially, within that first 1 to 2 months of starting a blocker or starting a GnRH agonist, you can actually have an increase in pubertal changes. And so if you don't warn your patient that this could happen, they have the potential to think that the medication isn't working and their dysphoria is going to probably increase even more. However, after about a month or two, those LH, FSH levels get turned off like a faucet. The hormones just get turned off and they drop down to zero. And that's when the pause comes. That's when there's not going to be any more progression through puberty. There's two types of GnRH agonists. So the first one, leuprolide, also very commonly known as Lupron. The Lupron depot IM, that's our intramuscular injection, and that's Lupron. Eligard is the subcutaneous option. You can get these as a monthly injection or every 3-month injection. The other option is histrelin acetate. This is known as either Vantis or Supprelin, and this is an implant. If any of you are familiar with Nexplanon, they're very similar. They're these kind of long, skinny rods. They're implanted subcutaneously in the medial aspect of the upper extremity, and really easy to implant or insert. Can be done just in an office setting, does not need surgery to be placed. And so this implant can be replaced every 1 to 2 years. These are quite expensive. You'll see that Vantis is about $5,000 a year, and it's not, or per implant, and it's not approved for pediatrics. It's only approved for adults. Supprelin, which basically Vantis and Supprelin have the same amount of hormone, the same type of hormone. Supprelin LA is $25,000 a year. It's approved for precocious puberty, but it is not approved for gender dysphoria. So these are a lot harder to get insurance to cover. I think actually Medicaid covers Vantis for gender dysphoria or gender incongruence. So that may be an option if you have Medicaid, but otherwise they're tough to come by. So if you can't get a GnRH agonist, there are other options. Progesterone, so our medroxyprogesterone or Depo-Provera, that's a shot that you get every 3 months. Micronized progesterone is an oral pill that you can take nightly. The only issue with progesterone is that it's just not as effective in lowering your endogenous sex hormones. So you're not going to get the same response that you would with a GnRH agonist. For our trans feminine individuals, there are 2 other options, spironolactone, and you can do dosing of 25 to 50 milligrams 1 to 2 times a day. Spironolactone is an anti-androgen. It's going to lower that testosterone level, the production of testosterone. It's not as potent. You're still going to get some testosterone, so it's maybe not ideal, but it's certainly an option. And then bicalutamide is one that's kind of newer, at least in the trans population or what we're using. It's not been well studied at all. It's a medication that's actually used for the treatment of prostate cancer, but it blocks testosterone at the receptor sites. And so your body is still producing the testosterone. It's just not getting utilized. It just can't get utilized. So I think this one's on the horizon. I think that it might be used certainly more commonly if we can get some more data on it. So side effects. GnRH agonists, the most concerning side effect is that it can affect bone mineralization. We typically see this if it's been used for more than 4 years without other hormones, without gender-affirming or cross-sex hormones in addition to it. And so that is a concern, but if you're using it for less than that, the studies have not shown any concern for bone demineralization down the road. Compromised fertility, mostly because, again, once you start a GnRH agonist, you're likely to go directly to a cross-sex hormone, in which case your fertility is going to be compromised. There's questions on its effects on brain development, especially in that frontal lobe, but there's not much evidence, not much data that discusses this. And then you can get injection site infections or infections after the implant. With progesterone, most commonly, certainly with Depo-Provera, you'll get a menses cessation. So for our transmasculine youth, if we can stop their period, if they've gotten it, that can be huge because the menses can be quite dysphoric as well. So Depo-Provera can often do that. You can get metrorrhagia with it, which is just kind of scanty, more frequent periods, kind of lighter periods, and that can be more dysphoric. So you have to sort of weigh the pros and cons there. You can get weight gain, absolutely, especially with Depo-Provera, depression, acne, headache. With spironolactone, so this medication is a potassium-sparing diuretic. So there is a risk for hyperkalemia, which is in excess potassium. I've never seen this in clinical practice, and the studies that have been done with spironolactone really find this to be a very low risk, but it is something you want to monitor. You can get increased urinary frequency, hypotension, and renal insufficiency all secondary to the diuresis. And then with the bicalutamide, again, we don't know a lot about it in this population, but what we've studied in the treatment of prostate cancer, there is a risk for hepatotoxicity. It's really low risk, like less than 1%, but it's certainly a possibility. You can get gynecomastia, which is the development of breast tissue. And this is often a desired effect for our trans feminine individuals. This is something that they want, so that can be an added bonus. With that gynecomastia, you can get breast pain, and then certainly you can get fatigue as well. So in terms of our follow-up, we're going to be seeing these kiddos every 3 to 6 months. I tend to be a little more conservative and like to see them at least every 3 months. And that's when we're going to just be repeating height and weight and blood pressure and checking Tanner stages. We're going to be doing labs every 6 to 12 months. Again, I'm closer to the 6-month mark is what I recommend, including ultrasensitive LH, FSH, estradiol, testosterone, vitamin D, and then your complete metabolic panel, especially if they're on anti-androgens. So you can look at the potassium and the liver function. This is kind of controversial in terms of whether or not we want to be doing bone density scanning and bone age assessment. I do like to get a bone age assessment as my baseline, but it's really controversial on whether or not it's helpful. And same with the DEXA. So I think that at least having some information baseline is helpful. And then if you need to repeat imaging or diagnostics, you can, but you may not need to. Okay, so when are we going to start our gender-affirming hormones? Endocrine Society recommends it starting at age 16, which is kind of the age of majority, right? The problem with that is that if you start somebody on a blocker at age 12 when they're in Tanner stage 2, and you don't give them any cross-sex hormones until they're 16, they're at a much higher risk of bone demineralization. And so that is a big concern. Also, from a psychosocial standpoint, it's really hard to have a 15 or 16-year-old who has the body of a 12-year-old, right? Especially when all of their peers are progressing through puberty. And so there's a lot more push kind of in the field to start hormones earlier so that they actually mimic when our cisgender peers are experiencing puberty. Again, it's got to be done individually, and it's got to be done, as part of kind of a fully supported treatment plan by the individual, the parents, and the providers, but it is something to think about. I just wanted to note there's a Dutch study that came out in 2011, and I think this is really important. Youth who reach adolescence with gender dysphoria are unlikely to revert to a gender identity that is congruent with their assigned sex at birth. Meaning, I often hear, well, Katie, are you sure that they're not going to regret their decision? Or, how do we make sure of this? Well, when a youth who has gender dysphoria, when that dysphoria gets worse with the onset of puberty, they are very unlikely to revert to the gender identity that's congruent with their assigned sex. We just don't see that. And so I think that we have to rest assured in that we're doing the right thing and affirming their gender. So when we think about goals of hormone therapy, it's pretty straightforward, right? We want to reduce the endogenous sex hormones, and therefore reduce the secondary sex characteristics. And while we're reducing those endogenous hormones, we want to use exogenous hormones to basically help them acquire secondary sex characteristics that align with their gender identity, right? So we kind of put them through puberty so that it aligns with their gender identity, and that's our main goal. In terms of the criteria for gender-affirming hormone therapy for adolescents, Endocrine Society and SOC7, they're really similar. They say that the gender dysphoria has to be pretty persistent, well documented. They've got to be able to make a fully informed decision and informed consent. Endocrine Society says they should be the age of majority in a given country, which is 16. Mental health concerns need to be reasonably well controlled. Both groups also say that gender dysphoria needs to have emerged or worsened with the onset of puberty, and that the adolescent, again, has demonstrated a long-lasting and intense pattern of gender nonconformity or gender dysphoria. So again, it kind of aligns with that, those symptoms being consistent, persistent over at least 6 months, but usually it's much longer than that. And then this is just taken from the Endocrine Society guidelines, and this is just basically what we've talked about. So you've got to have that mental health provider on board. The adolescent has to be able to give informed consent and understand the informed consent. The parents, I always have my parents of the individual sign off on the informed consent along with the adolescent. And then as the clinician, we just need to make sure that the indication for gender-affirming hormone treatment is appropriate, and that there's no contraindications for proceeding with it. So initiating hormone, first thing, we're assessing readiness, right? I talked a little bit about the referral letter from mental health professional, and this is kind of falling out of favor, and we're moving to a more informed consent model, which we've kind of talked about. It's noted that many adolescents by age 15 or 16 have a reasonable level of competence. So we can kind of assume that by this age, they are able to give informed consent, unless there's underlying limitations that we need to recognize. So once you've done the informed consent, you can then go ahead and decide which way you're going to go. How are you going to proceed with the puberty-inducing hormones? So for our trans feminine individuals, the question is, do we continue the blocker? If we want to continue the blocker, then you stay on that blocker generally until the serum estradiol level is about 40 or greater. If you don't continue on a blocker, then you'll start some type of anti-androgen. Most commonly is going to be that spironolactone. And so for your gender-affirming hormone, you're going to add low-dose estradiol. For our transmasculine individuals, again, you'll question if you want to continue the blocker. If you do, you keep it on until that serum testosterone is about 100 or greater. And then in the meantime, you're also starting your low-dose testosterone. So I won't go through this chart, but this is the chart that I used from the Endocrine Society. It's the protocol for induction of puberty. And I love this because it really breaks down the dosage in which we should be prescribing our hormones so that it most closely represents the physiologic response of their cisgender peers. Again, puberty takes a while to go through, and so you never want to start somebody on a really high dose because they're going to feel terrible, and they're not going to get the added benefit, the effects that they're hoping. So you want to do this slowly, and you want to be increasing the dose probably every 6 months or so, at least initially, until they're a little bit older, and then you can increase that dose a little more quickly. But I won't go through it, but here it is, and you can access this this paper is online and accessible to everyone. So in terms of our follow-up, we're going to want to see these kiddos every 3 to 6 months again. And I really like 3 months. That's kind of my standard. You're assessing height, weight, seated height, blood pressure, Tanner stages. You're doing labs every 6 months at least. Sometimes I'll do them more frequently if there's been something that's abnormal that's popped up. In our transmasculine individuals, we're going to be looking at hemoglobin, hematocrit, and we'll talk about why. We'll look at cholesterol, testosterone, vitamin D. In our transfeminine, individuals will be possibly checking a prolactin, although again, the evidence is not necessarily supporting that as much, but just definitely checking an estradiol, vitamin D, and then again, maybe doing bone age study or DEX every couple of years. Any questions before we move on to adults? Any questions with adolescents and children?
Katie, I'm looking through the chat box and I don't see any that have come up. I'll keep you
Okay,
posted.
cool. I'm kind of rushing through this. I want to make sure we get through all the material, but please stop me if I'm going too fast or if you have questions along the way. So for our adults, first thing is we need to make sure that the adults that we're treating are meeting the criteria for gender-affirming hormone therapy. And again, this is well documented in Endocrine Society and SOC7, and it's pretty similar to that of our adolescents. They need to have persistent, well-documented gender dysphoria. They have to be able to make a fully informed decision and sign off on informed consent, be the age of a majority in a given country. And then if there is underlying significant medical or mental health concerns, they need to be reasonably well controlled. So our feminizing hormones, what we'll generally do is obviously we'll start estradiol. That's the big one. We're going to base our dosing on desired effects. I have had a number of patients who identify as, let's say, gender diverse, right? And they just want a little bit of estradiol to help with some of the dysphoria that they're having without having full feminization effects. And so we'll do, what I call baby doses of estradiol. It really depends on what the patient is hoping for. And so that's how I base my dosing. We also don't want to do, I've had people say, I want to have as many feminizing effects as I can, as quickly as I can. Can you just put me on 10 milligrams of estradiol today? And we can't do that for a number of reasons, mostly because the adverse effects would be terrible. And so we don't want to start them quite as high. But generally what I do is we'll start and we'll sort of titrate over the next, 3, 6, 9 months. And our goal is to get serum estradiol levels in that 1 to 200 range. In addition to that, so that level, when our serum estradiol levels are like 1 to 200, it's not enough to suppress endogenous testosterone. And so we need to also add anti-androgens in order to suppress the testosterone. Typically, I'll use spironolactone and hopefully, adjust that dose in order to get a serum testosterone level of less than 50. Now, there's some anecdotal evidence out there saying that if we actually try to get our estradiol levels up closer to the 300 mark, then we may not need to use spironolactone because higher estradiol levels will actually suppress testosterone, and we could use a progestin instead. Again, it's not in the guidelines, so I haven't done that, but I'd say look for that on the horizon. There's also talk of using bicalutamide as well, again, which is going to prevent the testosterone from acting at the receptor site. If somebody isn't tolerating spironolactone, sometimes we'll do finasteride, which is a 5-alpha reductase inhibitor. And this medication is interesting. So it prevents the conversion of testosterone to dihydrotestosterone, and dihydrotestosterone is a much more potent form of testosterone, right? It's the one that does all the work. So we're preventing that conversion and keeping testosterone as it is. As that testosterone levels increase, they actually convert to estradiol. So with the finasteride, you do get a little bump in your estradiol level. You still want to have oral estradiol on top of that, but you may not need as high of a dose. Finasteride is not endorsed by the Endocrine Society, but it is recommended by WPATH. And another use of finasteride is actually in our transmasculine individuals, especially if they're experiencing male patterned hair loss. Then we can use the finasteride because it will help to prevent that hair loss. Finally, progestins, it's really unclear if there's benefit or harm. Again, anecdotally, I would say that there seems to be pretty significant benefit to progestins. People will often say that they have better breast development, more full breast development. They'll also say they sleep better, their mood is a little bit more stabilized. So a lot of people do use progestins, and if you're going to use it, just use the micronized progesterone. Medroxyprogesterone tends to be more androgenic, so therefore causing more androgenic symptoms, if you will, or side effects, and so it kind of defeats our purpose. But micronized progesterone is what I've used and has been pretty well tolerated. So our hormone preparations, typically what I'll do is I'll start somebody on an oral estradiol. It does not come as sublingual, but I always have my patients take it sublingually. It just helps to try and bypass that first pass effect by the liver. And usually I'll start at 2 to 4 milligrams a day. As I increase that dose, I'll have people divide the dose twice daily just to help keep those estrogen levels, estradiol, kind of more consistent throughout the day so they're not having big drops. Estradiol, the transdermal estradiol is another option. The problem here is that you have to wear multiple patches just because of how it comes. So often people will be wearing 2 to 4 patches at a time. It can be costly, but if insurance covers it, it's a great option. And it's definitely a safer one from a thrombotic risk, we'll say. So that is one that I use if people are at higher risk, if they've got obesity, if they're smokers, if there's other risk factors that are going to increase their risk for complications. Let's see, the estradiol valerate, that's the injectable estradiol, and usually I'll start people at 20 milligrams IM every 2 weeks and then adjust the dose as needed after that. Progestogens, again, the medroxyprogesterone I just don't use in this population, but micronized progesterone is there. And then our androgen blockers, our spironolactone, I'll usually start people at 50 milligrams twice a day and go up to 200 milligrams twice daily if I need to. Otherwise, I'll do finasteride anywhere between 1 and 5 milligrams daily. I just wanted to include this graph. So this graph looks at the way that different routes, different formulations of estrogen are broken down in our body, are metabolized, right? So it's important to note because estrone, so the red bars, so when you take estradiol, it's broken into estradiol like E2 and estrone, E1. It's important to note that estrone is much less effective. It's less potent. It doesn't do what we want it to do in terms of feminization. And so when we take oral estrogen, you can see that the majority of it is actually metabolized into estrone. And that's because of that first pass effect by the liver. When we take it sublingually, it decreases a little bit. But when we inject it or use estrogen transdermally, we get much more of the estradiol and less of the estrone. And what we really are going for is kind of a 4-to-1 ratio. So 4-to-1 being 4 of the estradiol, E2, for every 1 estrone, the E1. And that just mimics where perimenopausal women's levels are. And certainly we get kind of improved feminization that way. So risks of feminization, most notably, it's the venous thrombosis or thromboembolism. It certainly is a risk, and becomes a higher risk the older you are, and especially if you're a smoker or if you have heart disease or if you have obesity, any of those can also increase those risks. You can get a risk for cardiovascular disease, for weight gain, changes in libido, blood pressure changes, glucose changes, higher risk of gallbladder disease. There's a slight risk for benign pituitary prolactinomas. Again, this is pretty uncommon. We used to check a prolactin level annually on our transfeminine patients, but now we're only doing it if they present with neurologic changes or headaches, things like that. Breast cancer, that's always a big one that we talk about. And what the studies have shown us thus far is that our transfeminine women actually have a lower risk than their cisgender peers of breast cancer. So even though we're giving them these hormones, and yes, it does increase their risk of breast cancer compared to those not on these hormones, it's still lower than the cisgender females. Risk for infertility, absolutely. Does it come back if we remove the hormones? Possibly, but I don't like to bank on that. And then those risks of having a diuretic on board are those last four that we've already discussed. The effects of feminizing hormones are here. Really what I see typically or most early are those emotional changes, emotional lability, more tearful, change in libido, erectile dysfunction. I'll start to see breast growth, anywhere after a couple of months to 6 months. Definitely starts with breast budding and some breast tenderness. And then, it can take up to 3 years to really get that full or maximum breast growth. You'll get changes in body fat, and you'll get that redistribution of body fat more on the hips and buttocks. Muscle changes, you'll have less muscle, less strength, less endurance. Softening of the skin from that anti-androgen that you're on. In terms of the testicular volume, I definitely see this, and I would say that within the first year, absolutely, the testes become smaller and softer and likely decreases that sperm production. So our follow-up is going to be every 3 months again in that first year, and then 1 to 2 times annually. When we are following up with these patients, we want to assess for appropriate signs of feminization, make sure they're not having any adverse effects or reactions. I like to measure serum testosterone and estradiol every 3 months, and I generally like to check it first thing in the morning just so that my hormone levels are consistent every time I check their labs. Serum testosterone level should be less than 50. If it's around 50, then they still may be able to maintain erections when desired. If it's much less than 50, then they likely won't be able to maintain an erection. Our estradiol levels should be around 1 to 200. If taking spironolactone, probably check a potassium every 3 months or so, and if it's stable, then annually. Important in terms of routine cancer screening, it's really important that you follow the guidelines and that you follow what's recommended per the anatomy, right? The organ inventory. Colonoscopies are recommended for everyone at age 50. Prostate exams, if indicated, mammograms if sufficient breast tissue develops, starting age 40 or 50. And then consider screening for osteoporosis around age 60, depending on how compliant they've been with their hormone therapy. And this is just a chart that I've included that kind of breaks down when we should be checking for what lab and how frequently. And sometimes I stick to this, and then sometimes based on their individual response, I might do labs more frequently or less frequently. So masculinizing hormones, this tends to be a little more straightforward because really all we're doing is adding testosterone. And when we add testosterone, it suppresses the endogenous estradiol, so we don't need to use an estrogen blocker. Although, some people are using SERMs. I've not needed to, but maybe that will be on the horizon as well. And then typically we'll use either injectable or transdermal. There is the Testopel or a subcutaneous pellet that some people are offering. It's not evidence-based at this point, but I do hope that it becomes an option because I think it would be a great addition to to routinely offer these patients who are candidates for it. And then progestins may be used, especially if we're having a tough time causing menses cessation. Then you can maybe use a Mirena IUD or Nexplanon or Depo, and certainly for contraception. I've been saying that fertility can be compromised, and certainly for our masculinizing hormones, it's likely to compromise fertility, but we can't guarantee it. And so if you have a transmasculine patient who's engaging in intercourse with a cisgender male, there is a risk for conception. And so having something on board to prevent that may be necessary. Hormone preparations, I'm just going to go over the ones that I typically use. Testosterone cypionate, it's pretty easy to get, and usually I'll start people at 40 or 50 milligrams weekly. Sometimes people prefer to go every 2 weeks, in which case you'll just double that dose of hormone, and they'll administer it every 2 weeks. Most of my patients prefer weekly because they've reported that if you're doing it every 2 weeks, that closer to that second injection, or that next injection date, you start to get fatigued, you have emotional changes, even some depression. And so a lot of people do really well with the weekly injections. I definitely use testosterone gel or a compounded cream. And usually the gel is anywhere between 40 and 60 milligrams daily. And that can be a really good option actually for a lot of people if they have an aversion to needles. It may be cost prohibitive, though it can be quite expensive.
Katie, we do have a question that just came up.
Yeah.
Actually, it came up a few minutes ago. What is the Tanner stage?
Oh, yeah, sorry. So a Tanner stage is this staging system that we use to identify what stages of puberty somebody is progressing through. So Tanner stage 1 is no puberty, Tanner stage 5 is max puberty, and then 2, 3, and 4 are the different stages leading up to kind of your maximum pubertal growth. Does that make sense? And so there's, based on physical exams, we can determine where somebody is, whether they're Tanner stage 2 or 3 or 4. So hopefully that answers it. If not, shout at me again.
I'll follow up. Thanks.
Okay, cool. So risks of testosterone, it definitely can affect your HDL and your and cause an elevation in your triglycerides. So those are cholesterol. The most common one that I see is polycythemia, and that's an increase in red blood cells, specifically your hemoglobin and hematocrit. And really important that when you're checking these labs, we need to make sure that we're using the reference range for men, or the male reference range, because hemoglobin and hematocrit ranges for females are much lower than they are for men or males. And so we really want to make sure that when you're looking at these levels that you're using the appropriate gender. You can get male pattern baldness. Again, that's why we might use finasteride in this population if they are experiencing that. Variable effects on mood. I'd say most commonly I see a little more aggression, a little more irritability, less of that emotional lability, less tearfulness. Chronic pelvic pain is not one that I see commonly, but it can really be pretty it can be dysphoric for a lot of people, and it can just be a huge drag. It can be really annoying. We don't really know what causes it, but it is something that happens, and there's some thought that maybe adding progestin can help calm the pelvic pain down, but we don't really know. I wanted to bump down unknown effects on breast, endometrial, and ovarian tissues, especially cancer. We don't really know. We don't think that there's a big link to increased risk of cancer. We have done some studies where we've looked at the endometrial lining, so the lining within the uterus. Testosterone does a really nice job of keeping that lining really thin, which is why our transmasculine folks generally aren't having periods. And so there's not really a high risk of endometrial hyperplasia, and therefore not a high risk of endometrial cancer. We've not really seen a significant increased risk of cancer for any of these. And then finally, infertility, which we've talked about. So the effects of masculinizing hormones, first and foremost, I see clitoromegaly and voice deepening. So enlargement of the clitoris and then voice changes, in addition to acne. Those are the ones that I see most commonly, or certainly early on. Definitely some redistribution of fat and increased muscle mass. People will be like, Katie, I had no idea I had these muscles, because they will definitely start to notice these muscle changes. Typically, you'll get a loss of your period or cessation of your menses within 2 to 6 months of being on testosterone. And then long-term use, you might get some vaginal atrophy, in which case there's different strategies to address that. And then the male pattern facial body hair, and then the hair loss as well. But body hair typically will ramp up around 3 to 6 months. And then in terms of our follow-up, again, we're going to be seeing these patients every 3 months. And we're going to assess for signs of virilization and adverse reactions to the medications. We're going to measure a total testosterone every 3 months. And again, I like to do this first thing in the morning. If they're on injectables, then you want to make sure that you're checking your testosterone levels mid-cycle. So, halfway through their cycle, between when their next dose is due. And the goal is that it's around 4 to 700, 4 to 800. 800 might be a little bit high, actually. You can also measure what's called a trough level, and that's going to be your lowest level of testosterone. And sometimes I'll do this just to make sure that they are staying within that physiologic level of testosterone. If they're on transdermal, then you want to make sure that you check it at least 2 hours after they've last applied, and you want to make sure that they've been applying for at least a week. And our goal there is going to be closer to that 7 to 1,000 range. You're measuring your hemoglobin hematocrit every 3 months for the first year, again, to look for that increase. Polycythemia does tend to be related, or what we call dose dependent, meaning that the higher the testosterone dose, the more likely you are to get an elevation in your hemoglobin and hematocrit. Sometimes lowering that testosterone dose will take care of it. Otherwise, just donating blood every 3 months can be an easy fix. But it's definitely something you don't want to let go for a long period of time, and you certainly, there are associated risks if it gets too high. Monitoring weight, blood pressure, lipids, so cholesterol at regular intervals. And again, I usually do this every 6 to 12 months. For our transmasculine folks, if they have a cervix, then we need to be doing pap smears every 3 to 5 years, depending on what the guidelines say. And really important to be aware of how dysphoric this can be. And so often I will not use the typical stirrups when I'm collecting paps on these individuals. And I'll really try to be gender affirming throughout the procedure and do it as quickly as possible. Mammograms would be recommended if they still have breast tissue, again, per the guidelines. And then you'll want to do some type of annual breast exam if there's status post mastectomy, just to make sure that any remaining breast tissue isn't changing, or there's no masses or lumps or bumps in that tissue. And then here's
Katie,
the...
we do have another question. We just have
Okay.
5 minutes left before the top of the hour. Question here: what advice would you give for us to help support individuals transitioning medically?
Ooh. From a clinician standpoint, I wonder.
I think that's a safe assumption. Yeah.
Okay. So I'm going to say from a clinician standpoint, what I would encourage other clinicians to do is recognize that treatment has got to be individualized, and that while there's amazing guidelines out there, it's okay to veer off of these guidelines a little bit, as long as you're doing it in a safe manner, and really being supportive of the individual's end goal, because they're all going to be different. People have different goals, and we need to support that.
Great. And another question just came up. At what age do most of your patients begin their transitions?
Ooh.
Physically, not socially.
Physically. So when do we start our gender affirming hormones? I would say that I typically start gender affirming hormones around age 14 or 15, depending on how long I've been working with the individual. I would say on average. But we'll start blockers before then. Any other questions? This is actually my last slide. So here's my references. Questions, certainly feel free to shoot me an email. I'm more than happy to answer any questions via email afterward if they pop up, or if we've got a couple more minutes, I'd love to answer questions now.
We do. We've got a few more minutes. Another question came up. Is there an age at which hormones will no longer be effective for transitioning?
No. I would say that as individuals get older, their hormone needs decrease, but you still need some of those sex hormones. So just like cis females and cis males, start to their endogenous hormones decrease as they get older, right? Menopause, in your 50s and 60s. So you don't need as much hormone, but you still need some. I will say, though, I do have one client who is pretty happy not being on any hormone right now, actually, on any hormone. So again, it kind of varies, but you do want some type of, at least a small amount of sex hormone. Good question.
Great. Another question. Which of these services could be provided via telehealth? Which could not?
Oh, yes, great question. So I've had my first experience with telemedicine because of the pandemic, and it has been amazing. I have patients that live 4 to 6, 7 hours away. And so I've been able to do a lot of follow-up with some of my patients, my trans identified and gender diverse patients, across Montana over telemed, and it's been great. I can send lab orders to them. They can do labs in their own town. The results get faxed to me. I can review them. We can review together via telemed. I feel like a lot of the follow-up care can definitely be done via telemed initially. And actually, in the last couple of weeks, I've had a couple initial consults done over telemed, and so I think that's appropriate. For my youth, I like to be doing physical exams at least every 3 to 6 months. For my adults, it's probably less frequent, and so I feel like there's more wiggle room. So the long and short of it is, I wouldn't give it a finite number, but I would say that a lot of my follow-up care can be done via telemed, and a lot of the lab care can be done, or lab follow-up can be done in the individual's hometown.
Great. And just wanted to share a few comments that came up. Somebody said, this is excellent and it's appreciated. And someone else has said, this has been wonderful and so affirming. I've never heard a medical professional speak about medical management so compassionately. Thank you.
Oh, that just warms my heart. It really is. I'm so happy to be here, and this is such a passion of mine. So thank you for having me, and thank you for the positive feedback.
Wonderful. Katie, thanks so much. We should probably draw to close there. You've got Katie's information there. We are so lucky to have you as part of this summit and, of course, in our community here. Thank you so much for your time and effort with the presentation. So thanks again, Katie.
Thank you. Thanks for having me. And feel free to email me with any additional questions, please. I'm happy to entertain those as best I can.
Wonderful. Thank you.